This is part 2 of Pharmacology Basics, Module 1 for NUR 200 with Dr. Susan Lewis. Just to review, we are now on Objectives 5 through 9. Identify and discuss the stages of the pharmaceutic and pharmacokinetic processes. Discuss how the blood-brain barrier alters the absorption of drugs. Discuss the role of the liver and kidneys play in drug metabolism and excretion. Explain hepatic first pass and how it may affect drug dosages administered via different routes. And define half-life as it pertains to drug administration and assessment of the client. Okay, so drugs in the body. The greatest barrier for many drugs is crossing membranes. Enteral root drugs broken down by stomach acids and enzymes. And therefore, we have to time certain drugs because of these effects. Your organs are going to look at drugs and medications as foreign objects and are going to attempt to excrete the medications. In the liver, especially, phagocytes may attempt to remove medicines seen as foreign. So, when it comes to pharmacology, anytime you give a patient a medication, you're fighting an uphill battle against what your body wants to do naturally. There's 4 categories of pharmacokinetics: absorption of a drug, distribution of a drug, metabolism, and excretion of the drug. This is a good visual to look at absorption. Drugs get absorbed in the stomach and small intestine generally and enter the bloodstream, where they undergo distribution. From the bloodstream, any PO meds or enteral meds are going to be going to the liver for metabolization first, and then distributed again through the body. The large intestine and the kidney are primarily responsible for excretion of any drug metabolites that are left over after distribution and use by the body. So absorption of the medication is a movement from the site of administration across the body membranes to circulating fluids. Primary pharmacokinetic factor determining length of time for effective drug to occur. So this is when we talk about onset of the medication. A lot of it is how quickly it's going to be absorbed. The more rapid it absorbs, the faster the onset of the drug action. This is also a reason why the IV drugs, who do not have to be absorbed through the stomach and go across body membranes, oftentimes will have a much more rapid effect because of the method of absorption. Things that are going to affect drug absorption is the route of administration. Pills have to be broken down. If they have any kind of enteric coating, then that's going to have to be worn away by the stomach. IV medications are usually in a form ready to be used by the body. The drug formulation, syrup versus tablets. Often a liquid is going to be more easily absorbed than a tablet. The drug dosage can affect it. Also digestive motility. If the stomach is not moving and the small intestine is not moving, then often it may affect whether or not the drugs are going to get absorbed. If you have the appropriate enzymes in the digestive tract for absorption, sometimes the pH of the stomach may affect whether or not the drugs are absorbed, the blood flow at the administration site, and whether or not the drug is lipid soluble. Because lipid soluble medications are going to pass through the GI tract at a much more rapid rate than water-soluble medications. Other things to think about, like pH. Some drugs are taken on an empty stomach to allow for better absorption because the pH of your stomach changes when you eat. There's those drug-to-drug and drug-to-food interactions. We know iron gets absorbed better when taken with vitamin C, but does not get absorbed well when taken with dairy or calcium products. Grapefruit ingestion and statin drugs are no-no because grapefruit interferes with the hepatic metabolism of the medication and also interferes with the absorption of statin drugs. Also timing medications with antacids because oftentimes the electrolytes in the antacids as well as the change in pH with the antacids can change whether or not the drug gets absorbed appropriately. Dietary supplement and herbal products need to be watched as well because they may increase the intestinal transit time and reduce drug absorption. Distribution is that transport of pharmacologic agents to body tissues and fluids. Simplest factor is perfusion, the amount of blood flow to tissues. And then you look at the affinity to tissue. How well is that medication or that chemical going to attract to the tissue? And protein binding effect, which we'll discuss in a little bit. Physical properties of the drug have a big influence. Lipid-soluble drugs are generally absorbed better and have no issues with crossing membranes that water-soluble drugs have. Drugs bind with plasma proteins. So albumin, which you know I am a big fan of, is the biggie. And a lot of time, those drug molecules are going to form drug-protein complexes, and they bind reversibly to plasma proteins and never quite reach the target cells. When they're bound, they cannot cross capillary membranes. Okay? And worst case scenario, it may not be distributed to the body tissues. So let's say a drug is 95% protein bound, for example, Lasix. The bound portion of the drug is inactive. 5% of the drug is unbound and therefore active to cause an effect. And we know what Lasix does. It causes diuresis. As the, quote, free drug, that 5% in the circulation decreases, more of the drug is unbound and released to the circulation to continue its effect. So this is how, when they say Lasix lasts 6 hours, it means it takes 6 hours for that 95% protein bound to wear down so that the Lasix gets released from the protein binding as the drug is used up. After that, you would need to give another dose if you still want to have the diuretic effect. So let's take it the next step further. If your client had a low albumin level, is that going to affect how medications are going to be distributed? If they have a low albumin level, there's going to be less plasma protein with which to bind the medication, and it means there may be more medication available initially than normally would be. Let's talk about the blood-brain barrier. This is something for some reason I have trouble saying. Blood-brain barrier. It's a specific anatomic barrier, and it's built to prevent chemicals and medications from entering. Okay. The problem is it does make things difficult. We're going to talk about Parkinson's disease in a couple of weeks, and one of the biggest problems is that the patient needs dopamine. The pharmacologic form of dopamine will not cross the blood-brain barrier, in which case they needed to find a form that would cross the barrier. Because of this, it's difficult. Most chemo medications will not cross it. Okay? Antibiotics may or may not cross it. And this is the problem that people have when treating medications in the brain. Now, anticonvulsants and sedatives, yeah, they cross it, clearly. They were made and they will readily cross the blood-brain barrier. The other one to look at is the fetal-placenta barrier, and its goal and its purpose is to protect the fetus. No pregnant woman should be given medication without consideration of the condition, because we don't know what's going to pass. Things like alcohol, cocaine, and caffeine will cross, as well as many over-the-counter medications. So on this slide, we see a visual example of the blood-brain barrier, and clearly it's just a picture of a blood vessel and things crossing it. Okay, let's look at metabolism, which is the third step in the pharmacokinetics or the processing of medications. Metabolism changes the drug to a form that it can be excreted, and it involves biochemical reactions. The liver is your primary site. The liver is just an underestimated organ. It does a lot of stuff, one being metabolizing of medications. So when your liver fails, what happens to medications? Can they be excreted, or do they stay in this form and last a lot longer because of the liver's inability to metabolize the medications? So in the liver, there is a hepatic microsomal enzyme system. And if you become a nurse practitioner, you'll take advanced pharmacology and you hear all about the cytochrome P450 system. What you need to know is that there is an enzyme system in the liver whose job it is to inactivate drugs and accelerate the excretion. The populations you need to worry about, patients with hepatic disease, because their P450 system is going to be not working well, as is the elderly. Infants may have immature liver function, especially if they're premature. and grapefruit juice drinkers. Science has shown that grapefruit juice interferes with the P450 system. So that's why many medications shouldn't be taken with grapefruit juice. There's something called hepatic first pass effect. All medications that were taken enterally have to go through the liver prior to distribution to the general circulation. So it's going to be absorbed, it's going to go through the liver, and the liver is probably going to destroy or metabolize most of the medication prior to it ever reaching the tissues. That's why oftentimes you'll see PO medications have a higher dose than if they were given IV or sublingual. Only 20 to 40% of the PO medication available may be available to the circulation after that first pass metabolism. Things that bypass the first pass are things like sublingual, IV, transdermal or subcutaneous, or rectal. So it's just those enteral drugs, those PO medications that have to go through that hepatic first pass effect. Kidneys are your primary site of excretion. So once again, it's all about the liver and kidneys, and you have to worry about kidney function when giving medication. Some medications are exchanged or are excreted through the lungs. Anesthetics are a perfect example. And that's why in recovery oftentimes the nurses are big on getting the patient to take a lot of deep breaths so that they can get that anesthesia out of their system more quickly. And glandular through saliva, sweat, or breast milk. So there are some implications for breastfeeding mothers. We know caffeine can get transferred through breast milk, and anyone who's been breastfeeding and had a cup of coffee and then was up all night with their kid can relate to that. Half-life of drugs. This is something you hear a lot, but it's an important thing to know. The definition of half-life is the length of time needed to decrease the drug plasma concentration by 1/2. The longer the half-life of a drug, the longer it's going to take to get out of the body. And this is what helps determine how often a medication may be given. If a medication has a half-life of 12 hours, then oftentimes you're going to be giving your second dose in 12 hours. If the medication has a half-life of 24 hours, then you may have a daily medication. So here's an example. Adenosine IV push has a half-life of 10 seconds. And if anybody's given adenosine IV push, you know that you give it quickly, it works quickly, and the patient moves on. Narcan has a half-life of about 30 minutes to 1.5 hours. Narcan is one of those things that's in the news right now. Back to the adenosine. How fast do you think we need to push it? Well, it's very fast. If your client has a bad IV or decreased blood flow, there are some implications because the medication may not even have a chance to be absorbed or metabolized prior to its half-life. Narcan is used to reverse narcotics, and you know that it's being carried by some police agencies to address heroin withdrawal or heroin overdoses. The half-life of many narcotics is about 4 hours. So the implications of that is what? That somebody who receives Narcan for an overdose needs to be watched because the narcotic effect is going to kick back in once the Narcan wears off. Therapeutic ranges. We're going to talk a little bit about, when we talk about atrial fib, about loading doses and maintenance doses. And so it's about how drugs reach and maintain therapeutic range. Some medications require repeated doses in order for the amount of drug to accumulate in the bloodstream and reach a plateau where it's going to do the maximum effect. And the amount that you're giving is equal to the amount that's eliminated. This is one of those things, it's not a need to know, but it kind of shows how multiple doses of drug A are going to get it to the same place that not as many doses of drug B needs. Right, this is digoxin, and digoxin is one of those medications that needs to be loaded. The loading dose is usually a higher amount of drug given initially to elicit an immediate response. And the idea is you load up a patient on medication to get to that plateau faster. So with DIG, you would give 0.25 to 0.5 IV as a loading dose to follow with 0.125 or 0.25 milligrams IV as a maintenance dose. This ends part 2 of Pharm Basics. Stay tuned for part 3.